Hello, my name is Gabrielle Krebs. Welcome to my presentation for psychopathology and the role of the social worker. In this presentation, I'll review 5 major diagnostic areas that we've covered. Those areas are anxiety, bipolar and mood, personality, schizophrenia spectrum, and trauma and adjustment disorders. For each one, I'll walk through the main medications, how they work, their side effects, and why they're chosen. And then I'll add a practical, non-pharmacological intervention that social workers can use alongside medical care. I'll close by connecting all of this to the National Association of Social Workers Code of Ethics, here on out referred to as the NASW Code of Ethics, and to our professional obligation to evaluate and advocate for ethical whole person care. When treating anxiety disorders, we usually see a pattern of overactivation in the amygdala and low levels of serotonin. Those coupled together keep the body's fight or flight system on overdrive. The primary medication used for anxiety disorders is sertraline or Zoloft. Sertraline is a selective serotonin reuptake inhibitor, or SSRI, if you want to make life easier. It works by blocking the reabsorption of serotonin, so more of it stays active in the synapses. That balance reduces rumination, panic, and physiological tension. Typical side effects include nausea, sleep disturbance, and decreased libido. These side effects are usually mild, and they tend to fade within a few weeks, but social workers can help clients track what they are experiencing and communicate any concerns to their prescribers. A secondary medication is lorazepam or Ativan. Lorazepam is a benzodiazepine that boosts the calming neurotransmitter GABA. I'm Gabby. GABA. It provides quick relief during acute pain, but it can cause drowsiness, memory gaps, and dependence if it's used long-term. So social workers can reinforce the short-term safety planning and doctor supervision. The tertiary option is buspirone or Buspar. Also targets serotonin, but it lacks the sedative effects. This would be safer for clients that might have substance use histories. A highly effective therapy is cognitive behavioral therapy, or CBT. CBT helps clients notice catastrophic thinking, and it gradually helps them face situations that they might normally have fear in. Studies show that CBT matches medication in ineffectiveness, and it also can help prevent relapse when that medication is stopped. For bipolar and mood disorders, stability is everything. The primary medication for these disorders is lithium carbonate. It's one of the oldest and most proven mood stabilizers. Lithium works by balancing dopamine and serotonin transmission, which lowers the mania intensity and can prevent depressive crashes. Side effects might include hand tremors, thirst, weight gain. At high levels, it can strain kidneys and thyroid. Clients need routine blood monitoring, and social workers can help coordinate labs and education around hydration. A secondary medication for bipolar and mood disorders is valproate or Depakote, which increases GABA and slows nerve firing to reduce manic cycling. Some side effects with these medications might include fatigue, hair loss, liver function changes. Social workers can encourage clients to report unusual bruising or abdominal pain early. The tertiary option is lamotrigine or Lamictal, and this stabilizes mood by decreasing glutamate activity. Its main caution is a possible rash called Stevens-Johnson syndrome, so clinicians increase that one gradually as they're figuring out dosage. Therapeutically, interpersonal and social rhythm therapy, which is IPSRT, that teaches clients to regulate their daily rhythms using consistent sleep, consistent meal times, consistent social routines. These stabilize the client's biological clocks, which can be linked to mood. When medication maintains chemical balance and IPSRT builds predictable structure, clients experience fewer episodes and greater control over their daily life. The social worker's job with these clients is to link the medical and behavioral worlds by tracking adherence, monitoring side effects, and addressing environmental stressors. For personality disorders, medication can support emotional regulation, but it cannot change just personality traits on its own. The primary medication is going to be fluoxetine or Prozac. Fluoxetine is an SSRI. It increases serotonin to improve impulse control and reduce irritability. Side effects often include insomnia or mild gastrointestinal upset. A secondary option is carbamazepine or Tegretol. That acts as a mood stabilizer and can help people who swing rapidly from anger to despair. It might cause dizziness or lower white blood cell counts, which could require occasional labs. The tertiary medication is aripiprazole or Abilify. It's an atypical antipsychotic that fine-tunes dopamine and serotonin. It helps with impulsive behavior and can lift chronic emptiness, but it can also cause restlessness or metabolic weight changes. The best supported therapy for those with personality disorders is dialectical behavior therapy, or DBT. This was developed by Marsha Linehan in 1993. DBT combines CBT skills with mindfulness to teach clients how to tolerate distress, regulate their emotions, and communicate effectively. Social workers often use DBT groups to promote peer learning and accountability. Here, pharmacology reduces crisis intensity, and DBT provides the lifelong coping framework, which is a true synthesis of symptom management and behavioral transform. With schizophrenia spectrum disorders, treatment has to target their hallucinations, delusions, and the social isolation that follows. The primary medication is risperidone or risperidol. Those block dopamine D2 and serotonin 5-HT2 receptors to reduce positive and negative symptoms. Side effects of these medications might include weight gain, fatigue, elevated prolactin levels, and these can affect mood and energy. If that fails, the secondary medication is clozapine or Clozaril. It's used for treatment-resistant cases. It does have excellent symptom control, but it can cause a granulocytosis, which is a dangerous drop in white blood cells, so clients need weekly blood draws early in treatment. Social workers can often coordinate those appointments and educate families on early warning signs of infection. The tertiary medication for schizophrenia spectrum disorders is haloperidol or Haldol. It's a first-generation antipsychotic that powerfully blocks dopamine, but it can cause stiffness or tremors called extrapyramidal symptoms. Once those symptoms decrease, cognitive remediation therapy, or CRT, helps rebuild attention, memory, and problem-solving skills. Research by Vandenberg and Vandergag also show that integrating eye movement desensitization and reprocessing, or EMDR, for clients with trauma histories can help them reduce their intrusive thoughts. Together, medication corrects neurochemistry, while therapy restores that cognitive function and self-efficacy, supporting both recovery and community reintegration. So clients with trauma or adjustment disorders often struggle with flashbacks, nightmares, and emotional numbing. The primary medications for these are going to be paroxetine or Paxil and sertraline or Zoloft, which we talked about previously. Both of these are SSRIs, which help regulate serotonin and reduce intrusive memories. Side effects might include stomach upset, sleep changes, sexual dysfunction. Social workers normalize these effects and encourage continued communication with prescribers. The secondary medication, prazosin, blocks the alpha-1 receptors to decrease nighttime adrenaline surges and nightmares. Short-term benzodiazepines might be used in acute stages, but we would need to educate clients on dependency risk and emphasize alternatives like relaxation training. The leading therapeutic approach is eye movement desensitization and reprocessing, that EMDR. During EMDR, clients recall traumatic events while following guided eye movements, helping the brain reprocess memories without triggering full emotional distress. Research has found that EMDR significantly reduces post-traumatic symptoms, even with clients that do have psychotic features. The combination of SSRIs for biological stabilization and EMDR for memory integration creates trauma-informed framework that values safety, empowerment, and meaning-making. The NASW Code of Ethics reminds us that our role extends beyond individual treatment. Under social welfare and social political action, we're responsible for advocating against unethical systems. Things like pill mills, over-medication, and the political power of pharmaceutical companies. Ethical practice means ensuring informed consent, discussing side effects honestly, and helping clients access non-pharmacological options when possible. That also means supporting policies that make therapy and medication equally available to all populations. When social workers integrate clinical skill with macro-level advocacy, we promote both health equity and professional integrity. Even though medication is vital for bipolar disorder, it's not perfect. Lithium can cause tremors and kidney strain, valproate can raise liver enzymes, and lamotrigine can lead to rash concerns. Clients often discontinue treatment because of weight gain, fatigue, or emotional blunting. And while these drugs stabilize mood, they don't address thought patterns, family conflict, or life stress that often triggers that relapse. Research by Geddes, Miklowitz, and Lam show relapse rates drop dramatically when medication is combined with therapy. That's where social workers come in. We educate, we motivate, and we coordinate. We normalize the adjustment process, we troubleshoot those barriers, and we empower clients to participate actively in their own treatment because their voice is very important. A strong evidence-based approach is cognitive behavioral therapy for bipolar disorder, or CBT-BD. It teaches clients to track their triggers, spot early warning signs of mania or depression, and challenge their extreme thinking. Ching et al. And Geddes et al. Found that CBT-BD, when combined with medication, leads to fewer relapses and improved emotional control. Clients do learn relapse prevention plans, sleep regulation, and problem-solving skills that medications alone can't provide. CBT-BD represents the partnership between medical stabilization and cognitive empowerment, which is exactly the kind of collaboration that our field values. In practice, effective care follows a cycle of assessment, intervention, and evaluation. Assessment starts with the baseline mood tracking using questions like the mood disorder questionnaire. Implementation comes with medication, often lithium, with weekly CBT-BD sessions, and consistent communication among the psychiatrist, therapist, and their family. Evaluation means re-administering tools such as the Beck Depression Inventory and reviewing relapse frequency every 3 months. If progress stalls, the plan is revised, the dose can change, we introduce new coping strategies, or address what social stressors are happening. This continuous feedback process aligns with the NASW's principle of competence. We must measure, adapt, and stay accountable for client outcomes. When I think about the role of a social worker, I see it as existing right where biology, psychology, and ethics all meet. Our job is to hold both sides of the treatment process, the scientific and the human part, accountable. That means understanding the neurochemistry behind medications, but also recognizing how environment, identity, and life experiences shape a person's recovery. Social workers are often the ones helping clients navigate the hard parts, explaining side effects in plain language, building motivation for adherence, and challenging the stigma that still surrounds medication and therapy. We also push for fair access to both because real wellness isn't possible when cost or culture becomes a barrier. There are questions that we should always keep in mind, which are, how can we protect a client's autonomy while still emphasizing the importance of consistent treatment? What systems or cultural attitudes keep people from receiving balanced care? And what would it look like if every treatment plan focused on empowerment instead of just symptom control? With evidence-based therapies like CBT, DBT, ISRT, and EMDR, all the acronyms. They're combined. When those are combined with the pharmacological support, treatment becomes holistic. Clients can gain stability from medication, but also insight, coping skills, and connection from therapy. That kind of integrated care represents the heart of ethical social work, healing that values science, dignity, and the person as a whole. The information in this presentation comes from these sources. Together, these show how ethical, evidence-based pharmacology and social work practice merge to promote long-term healing as well as justice. Thank you so much.